Hello, my name's Joel Dunning. I'm here at STS 2024 in San Antonio with the one and only Bernie Park. So great to have you here, of obviously the father of robotic surgery, and it's incredible to think that you published the first series nearly 20 years ago, and so must have been doing robotics for 20 years, and how the landscape has amazingly changed. And you're here, you're just about to step into a session arguing for robotics over VATs as an economic argument. And so maybe you could just say a few words on what you'll be saying to the STS today, and how we phrase this argument for robotics over VATs.
Sure. Thank you, Joel, and thanks for the opportunity to talk today. You're too kind with that introduction. I'm not sure about the father of robotics. I want to remind everybody actually that Franca Melfi, if I'm the father, then she's the mother of robotic thoracic surgery. So yeah, it's been a long journey, 22 years from when I did my first case in 2002. We've seen a lot of changes in the landscape of surgery, really a transition to minimally invasive approaches as the standard of care. And yeah, we have the opportunity today to talk a little bit about what the arguments are for robotic procedures in thoracic surgery. But it's interesting that it's almost as if the argument is a moot point. One of the things I'll mention in my talk is there have been recent studies published from non-voluntary databases, insurance databases in the US, that show now that robotic approaches to lobectomy are the dominant approach. The curves crossed over sometime about 2 or 3 years ago, and more than 60% of lobectomies done in the United States are done by robotics. And so to some degree, the decision has already been made a little bit by the consumers, and by consumers I mean patients and surgeons. But we are tasked today to talk a little bit about what's the data in terms of pain and recovery, and what are the cost considerations of robotics. And we are lucky that even though it seemed unlikely, we now have 4 published randomized trials. 2 were done largely in Europe, 1 was done in China, and they really are excellent data to support what the actual information that's available to make these decisions. And then the other portion is the cost considerations. Now, believe it or not, 15 years ago, I actually did a small cost study at our hospital where I looked at the charges associated with VATS or robot or thoracotomy. And I think most simple charge studies showed that the charges for robotic approach are greater than VATS, no question, hands down. And that's mainly due to the cost of the robotic instruments and the disposables. And then on top of that, if you add things like capital depreciation or amortization, that further increases the theoretical cost of the robotic approach. However, actually, one of the studies that I'll talk about, 2 very important studies. One was out of Ohio State University a couple of years ago. Peter Nurtz and his group showed that at tertiary facilities, at high academic facilities, if you lower things like OR time, disposable use, that you can get to a cost-neutral position between robot and VATS and thoracotomy. And the second study, which is really a very good study by Hayden and colleagues, Benj Kozauer was the senior author from WashU, where they did a true cost-effectiveness study where they made decision models of VATS, robot, thoracotomy, and then a second decision model of just VATS and robot. They basically tested several factors that would go into the cost or the charges associated with lobectomy by any of those 3 modalities, and they expressed it in the added cost per quality of life year gained. And what they showed pretty convincingly was that yes, the robotic approach had an increased cost per quality of life year, but it was well within what you would accept for new technology. So they expressed it in the level of how much you would pay extra. So there were three quartiles: $50,000 US, $100,000 US, or $150,000 US. And that study showed that basically that if you assumed $200,000 or less quality of life year cost, that was acceptable for the robotic approach. Yes, the VATS approach was the cheapest, but all you had to do was increase utilization of robotics for all lobectomies by 3.6%, and it would become essentially cost effective. Cost effective, not cost neutral, but cost effective.
So yeah, I mean, it's absolutely so amazing to see that now America is leading the way, robotics being the primary way of doing lobectomies. And as you say, it's amazing that now we've gone all the way to randomized trials that we never even thought. So almost a slam dunk. But maybe you could take a step back, because obviously 22 years ago it was 3 arms. You had to scrub back up to do the stapling.
Yes.
And now it's so much different. Maybe I wonder if you could give us your insights on what the next 5 years might look like, because I'm sure most people watching this video are actually robotic surgeons already, but they'd be excited to hear from you what you think is going to be happening in the next few years in the world of robotics.
Yeah, I mean, it's already happening now. I think that one of the themes of my talk is going to be that it's pretty clear that in general, and particularly if you're going to utilize robotics, we want to work to minimizing the costs and maximizing the outcomes for the patients. Currently, there's a single port system where, so for instance, in Europe and in Asia, uniportal VATS is a very dominant subsection of VATS, multi-port VATS, that promises less pain, a little bit quicker recovery, and so we now have a telerobotic system where you can utilize a single port access. Outside the cage access, so subcostal approaches to lobectomy, subxiphoid approaches to thymectomy. So that's already here. The FDA is considering approval of the single port systems for use in thoracic surgery. And so I think, again, less incisions, less invasion, perhaps less intercostal trauma, is the way of the future.
Yeah, so that'd be quite soon. I mean, Ying-Kai Chow's done like 100 lobectomies in Taiwan, hasn't he? And then
Yes.
Brigham and Women's have done, the robotic thymectomy uniportal
Yes.
approach, which I hear is incredible. So that's coming, isn't it, soon? Yeah. And what do you think the world will look like? Because obviously competition we talk about for years. You probably talked about it for 20 years, haven't you? But actually it really is coming. So Britain's got a robot, Medtronic's got a robot, Suzuki's got a robot, Shiguri's got a robot. Where do you think it's going to end up in 5-10 years?
I think that I think the ideal scenario is that in 5 to 10 years, like any other technology, the competitors are going to catch up and they're going to continue to innovate and get better. I think an analogy is I believe that the Chinese electric car company now has exceeded Tesla, which was the dominant, the elephant in the room, but now they are no longer the world's largest supplier of electric vehicles, Tesla. So I think in the same way, the competition will be healthy and good. It will continue to innovate and allow us surgeons to translate those innovations to benefits for our patients. So I think you're going to see more alternative systems. I think you're going to see outside the box thinking. And we're not even talking about how AI would integrate with this, or localization techniques, things like that'll be wedded to the approaches. Yeah,
and one thing that people sort of don't talk about too much, but actually is definitely coming, is metrics. Actually, online, real live metrics, where perhaps intuitive or record your video and feed back to you your quality of surgery. Do you think that might change the field for good? And how close do you think that actually is?
I think it's very close. There are a lot of platforms now where the cases are being videoed, and you can get machine learning to really to compartmentalize the case and to analyze your movements and your efficiencies. And so I think that's coming. I think it's medical legally, it could be a little bit difficult in the sense of if every case now that's done is being recorded, then is that Is that something that needs to be preserved? Is it the right of the patient to have access to that, or have access to the analysis of the data of the quality of the surgery they undertook? That's a very tricky subject, I think.
Link it to surgeon payments. You get 20 out of 25. You get paid that. Yeah, no, that's a good point actually. Because obviously we're going to create these metrics, and then it's what you do with them, isn't it? So yeah.
I mean, an analogy is that in America now, it's a state law that anything that is in the medical record, which includes reports, pathology reports, radiology reports, the patients must have immediate access to those reports on their online, on their portal, or their their e-medical records. So it's really an interesting time, coming forward.
Yeah. And finally, the fifth generation's coming up, isn't it? So actually, people need to look out for this. I hear it's actually going to be announced, very, very soon.
Yes.
What would your guesses be to what's going to happen, or do you tell us anything about that?
I must say, I don't have any direct knowledge of that. I've had some snippets here and there. I think it's interesting, if you look at the core benefits or the core innovation of robotics, it really hasn't changed in 22 years, meaning binocular vision, wristed articulated instrumentation. I think in this iteration of the robot, the arms are largely the same. I think there's going to be vast improvements in the surgeon console, both the ergonomics of it, the utility. I think there's also going to be a lot of enhancements of what you can do, again, with AI and as you're operating, as far as localization and things like 3D segmentation that you can have it available while you're doing this surgery. So
yeah, well, thank you so much for coming to talk to us. It really is an incredible journey that you've had in these last 22 years or so, and I'm sure the next 22 will be quite fun as well.
I don't know if I'll be around for the next 22 years, but Joel, thank you so much.
Well, you've taught pretty much everyone in America, so you've left a pretty good legacy. Thank you so much for coming to talk to us.
Thank you. All right, enjoyed it.